Hello everyone, and welcome to this inaugural lecture. In previous years, we all would have been together on campus for this event, but like last year, most of us have to get together virtually. If initially we thought that getting through this pandemic was going to be a sprint, we quickly came to realize that we are running a marathon, and now it has morphed into an ultra-marathon. But thankfully, we have been able to innovate, and by this stage, this new virtual reality where we see each other on screens has, to a certain extent, become the new normal. Regardless of the method of delivery, an inaugural lecture is cause for celebration and a huge milestone in an academic's professional life. It's an opportunity for someone recently appointed or promoted to full professor to share their research and insights with colleagues, students, and the public at large. Intreeredes soos die is een van die hoekstene in die lewe van akademici. Dit bied aan gerespekteerde kenners in hul veld die geleentheid om openlik kennis te deel, iets wat sedert die ontstaan van universiteite nog altyd deel was van die akademiese projek. And the plus side of this lecture being virtual is that its content can be shared and seen by a very large audience and educating generations to come. This quote by the biologist Thomas Huxley speaks to the quest of universities today. The medieval university looked backwards. It professed to be a storehouse of old knowledge. The modern university looks forward and is a factory of new knowledge. These words might have been spoken more than 100 years ago, but they still ring true. Inaugural lectures are a prime example of where new knowledge can lead us, an affirmation of the cumulative effect in-depth knowledge can have on the career trajectory of an academic individual, and also a testimony to the influence academics have on their fields of expertise. Maar is professore steeds nodig in tye waar almal toegang tot 'n magdom inligting het met net die druk van 'n knoppie? Ek wil sê meer so as ooit. Ons leef in tye waar ons op professore se kennis en insig, ervaring en wysheid moet kan staatmaak. Daarom hou ons die ampt van professor in stand en gee ons graag die geleentheid aan elk van ons professore om 'n intreerede te hou. The science fiction writer and biochemistry professor Isaac Asimov's words come to mind. Anti-intellectualism has been a constant thread winding its way through our political and cultural lives, nurtured by the false notion that democracy means that my ignorance is just as good as your knowledge. In times of fake news, we have to celebrate the quest for true knowledge and the effort that accompanies it. So I congratulate our first-time full professors on the journey you undertook to get here. And for our audience, I hope you enjoy the lecture.
Honored guests, members of the academic community, and friends, good evening, goeienaand, molweni. My name is Jimmy Volmink, and I am the Dean of the Faculty of Medicine and Health Sciences at Stellenbosch. At our faculty, we love making history, and today is no exception. Thanks to COVID-19, this is the first time ever we are hosting a professorial inaugural lecture in a virtual format. Ladies and gentlemen, it gives me great pleasure to welcome you all to this event on behalf of the faculty. I'd like to extend a special word of welcome to our speaker, Professor Kathryn Chu, as well as to her family, friends, and colleagues from around the globe. Achieving the rank of full professor is a very high point in the life of an academic, and we are delighted to be able to celebrate this achievement with Kathryn. Before inviting her to address us, I will introduce her briefly by referring to her biographical sketch showing her stellar career so far. Kathryn Chu was born and raised in a small Midwestern town in the United States as a first-generation Chinese American. She received her undergraduate degree from Stanford University in biology with honors, after which she completed medical school at the University of California, San Francisco, UCSF. Kathryn discovered her love of global health and surgery while working at a rural mission hospital in Kenya, as well as later in Lesotho as a junior doctor. She later returned to UCSF for her general surgery training. During this period, she was awarded a Fulbright scholarship to study at the London School of Hygiene and Tropical Medicine, where she obtained her master's degree in public health in developing countries. As a qualified general surgeon, she headed back to Africa to work in rural Zambia at Makar Mission Hospital. Kathryn subsequently completed a colorectal surgery fellowship at the Leahy Clinic in Massachusetts and joined the Johns Hopkins Medical Institution as an associate professor in surgery and international health. While working at Johns Hopkins, she conducted a global health research project in Cape Town, which demonstrated the protective effect of helminth infections on patients with inflammatory bowel disease. Dr. Chu later worked as a humanitarian surgeon and a surgical advisor for Médecins Sans Frontières, MSF, South Africa, for 4 years, where her responsibilities included conducting operational research, improving clinical protocols, and identifying gaps and barriers in service provision. After this period with MSF, she decided to follow her career in providing surgical care and training surgeons in the government sector. First, she joined the Human Resources for Health program in Rwanda, training surgeons in a country whose medical workforce had been decimated by genocide 30 years before. She then returned to South Africa and worked in district and regional hospitals in Mpumalanga and KwaZulu-Natal before ending up in the Western Cape. Kathryn initially worked as an associate professor of surgery at the University of Cape Town for a few years, before being appointed as professor of global surgery and the founding director of the Center for Global Surgery in our Department of Global Health at Stellenbosch. Professor Chu is an NRF-rated scientist with over 80 peer-reviewed publications to her credit. Her research focuses on evidence-based solutions to providing high-quality and timely access to surgery in resource-limited settings. She currently serves on the editorial boards of the World Journal of Surgery, the British Journal of Surgery, and the BMC Public Health Journal. Through a Discovery Foundation Distinguished Visitor Award, she actively contributes to building surgical capacity in the Northern Cape Province. She also works with various international and national advocacy groups, including the College of Surgeons of East, Central and Southern Africa, the South African National Department of Health, and the Association of Surgeons of South Africa to strengthen surgical systems. Professor Chu currently serves as a board member for the Consortium of Universities for Global Health and One-to-One Africa. She is the immediate past president of MSF South Africa. In summary, Kathryn Chu's career to date has been committed to building a pipeline of future global surgery leaders through capacity building and mentorship, with a special focus on Africa. It gives me great pleasure to invite Professor Chu to address us now on her chosen topic, Decolonizing Surgery, a Call to Action.
Thank you, Prof. Volmink, for that kind introduction, and thank you to the faculty for allowing me to give this inaugural lecture on a topic that I feel passionate about, decolonizing surgery. I have been a surgeon for 20 years. Surgery is an amazing profession and craft, and I love the precision, innovation, and teamwork that successful operations require. I have dedicated most of my surgical career trying to understand barriers to surgical access. In this lecture, I propose that, like other global health issues, the lack of access to surgical care is in part a consequence of structural violence and neo-colonialism. Surgery has ancient roots in the Middle East and Asia. The first anesthetic is credited to the Sumerians in 3500 BC in Mesopotamia, present-day Iraq, who harnessed the opioid properties of poppies. In 600 BC, an Indian surgeon, Shoruta, performed various procedures such as hernia repairs, C-sections, and even neurosurgery using wine as an anesthetic. However, perioperative mortality and morbidity were high without an understanding of antisepsis. In the last 200 years, advances in surgical science and technology shifted from Asia, Africa, and the Middle East to Western Europe and North America. Dr. Joseph Lister, a British surgeon, is considered the father of modern surgery because of his work on cleaning wounds and sterilizing instruments in the middle of the 19th century. Following his work, post-operative surgical infections dropped dramatically and operations became a whole lot safer. In 1846, the first operation under general anesthetic using ether was performed in the United States by Dr. Colin Warren, a renowned American surgeon who was also the first dean of Harvard Medical School and the founder of the medical journal, the New England Journal of Medicine. A dentist, Dr. William Morton, administered the general anesthetic using ether. In modern times, the vast proportion of operations and patents for new surgical technology, such as robotic surgery, occur disproportionately in high-income countries. My thinking and beliefs around reasons for the lack of high-quality surgical care in low and middle-income countries, or LMICs, and the need to decolonize surgery are intimately linked to my personal journey. I was born in the United States, but my parents, grandparents, and all the generations before that I know of were born in China. Someone once told me that privilege is an accident of birth. It's not something we earn, but are given. While my paternal grandparents were fleeing China during the Civil War in the 1940s, their youngest daughter, my aunt, was unfortunately left behind. While I grew up as a middle-class American, my first cousins were raised in poverty in China under the communist regime and denied an opportunity to receive the first-class education that I had in the U.S. My aunt contracted meningitis and was left with permanent disability because the family had no access to quality health care. Consequently, my immigrant status started me thinking about the root causes of social and health inequities. In the US, we celebrate Columbus Day, which commemorates the discovery of America by Christopher Columbus, an Italian explorer, in 1492. He mistakenly called the indigenous population American Indians since he thought he had landed in India. After his arrival, settlers from multiple European nations followed, leading to the colonization of the Native Americans. This led to the introduction of infectious diseases such as smallpox, which wiped out 90% of the local population. Colonialism is the policy or practice of acquiring full or partial political control over another country, occupying it, and exploiting it economically. Under colonialism, there is not only economic exploitation, but adverse effects on health and well-being as well. Colonialism became more personal when I visited Tibet in my 20s. Ethnically, I am Han Chinese, part of the dominant group in China, whose Communist Party also rules the country. Populated by Buddhists and ruled by the Dalai Lama, Tibet was an autonomous region for hundreds of years until colonized by the Chinese in the 1950s. While the Chinese Communist Party argues it has brought new roads, jobs, and better housing to Tibet, it has been criticized for the systematic destruction of the Tibetan culture and the Buddhist religion under the guise of modernization. Health indicators have not improved since their occupation, with high rates of infant mortality, malnutrition, and infectious disease. In addition, 1 out of every 5 city hospitals in Tibet does not have surgical services. My time in Tibet allowed me to see firsthand the long-term structural inequities created by colonialization, including access to health care. Upon graduating from medical school, I wanted to work in a setting less resourced than the US. I started this journey at a rural mission hospital in the foothills of Mount Kenya. It was there that I discovered my passion for surgery. The HIV epidemic was raging at the time, but antiretrovirals were not yet readily available. The medical ward was full of immunocompromised patients for which little could be done. The surgical team, however, was saving lives. The results were immediate. An exploratory laparotomy and a bowel resection for sigmoid volvulus allowed a man who had been seemingly at the brink of death 1 week earlier walk out of the hospital with no perceptible disability. I also enjoyed the patient-centered care in this type of rural environment. The patient's culture and beliefs were important consideration in the treatment plans. This was a big contrast to the biomedical emphasis of surgical care that I learned in the ivory towers of San Francisco academic hospitals, where I had done my formal training. I confirmed my commitment to becoming a surgeon after working at a second rural hospital in the highlands of Lesotho. During this time, I started to consider how mission hospitals fit into the government health system. In my experience, the mission hospitals functioned outside the government sector, serving large rural catchments that had no other health coverage. Their independence allowed them to be effective without depending on unreliable government supply chains or staff shortages. On the other hand, the impact of their successes on health system strengthening was limited. These hospitals were staffed by expatriate doctors, and engagement with local health officials seemed to be minimal. After these experiences, I thought about the inequity of the excellent surgical care that these mission hospitals provided, while much of the rest of the country did not have access to the same resources. I wondered, how could these skills and capacities be transferred to the rest of the country to strengthen the surgical system nationally? Upon returning to the US, I started my surgical residency. I received outstanding clinical training, but did not learn about the role of surgery within the broader health ecosystem, nor the impact of a functioning health system on the success of surgical care. This led me to pursue a Fulbright scholarship to study at the London School of Hygiene and Tropical Medicine, which gave me a public health lens through which to consider surgical care. And this experience led me to my dream job. Upon finishing my surgical training, I joined Médecins Sans Frontières, or MSF, a humanitarian medical organization. MSF provides surgical care in over 30 sites in 18 countries, performing over 100,000 major operations annually. During my time with MSF, I began to think about how the legacy of colonialism resulted in structural violence. Structural violence is a term coined by Johan Haltung, a Norwegian sociologist and founder of peace and conflict studies, which describes social structures, economic, political, legal, religious, and cultural, that prevent individuals, groups, and societies from reaching their full potential. Examples of structural violence include disparate access to resources, political power, education, and healthcare. Structural violence is a major barrier to surgical care. War and internal conflict prevent persons with traumatic injuries or other emergency conditions from receiving health care. At MSF, we demonstrated that in conflict settings, cesarean section for obstructed labor and injury care were the most common operations needed. These procedures, among others, require a hospital structure, laboratory, X-ray facilities, as well as the ability to transfer patients if needed. Corruption and poor management prevented infrastructure upkeep in many hospitals where MSF works, and without these facilities, surgical care becomes limited. Political and social economic factors made patient transfer risky in some contexts due to hijacking, and many could not reach the care that they needed. A dramatic example is from 1994, during the Rwandan genocide. MSF was working in Rwanda during July of that year when the death of the Rwandan president and Hutu, Juvenal Habyarimana, sparked the systematic killing of 1 million ethnic Tutsis. Countless persons were injured, but surgical access was deplorably limited. MSF could only use a football stadium to treat the wounded, where we could not perform operations with sterile conditions nor proper anesthesia. In addition, we were unable to transfer the wounded to any other hospital. Colonialism involves physical occupation and overt economic exploitation, but neo-colonialism can be more subtle. Professor Rafael Perez Eskayama, director of the Yale School of Public Health's Global Health Concentration, writes, "The neo-colonialist approach is rooted in a legacy of the strong, unjust social, political, and economic systems established since colonial times. As such, the neo-colonialist approach to public health assumes that less economically developed nations have health problems that only white men from economically advanced, powerful nations know how to solve. Furthermore, it assumes that lower-income nations do not have cultural or social assets of value, and that they are inhabited by ignorant and uncivilized people. In other words, it is based on white saviorism, and hence neo-colonialism is also intrinsically racist. The neo-colonialist approach in public health imposes top-down solutions without consultation with local communities. My time with MSF raised questions about the top-down neo-colonialism of emergency humanitarian assistance. I started asking myself, do humanitarian aid organizations develop local and sustainable surgical capacity? The mandate of MSF is to focus on emergencies in conflict and disaster settings. But some of the settings in which we work have fragile health systems at baseline with limited surgical care. What happens when we leave? Examples of this type of neo-colonialism in humanitarian assistance occurred during the 2010 and the 2020 earthquakes in Haiti, a country extremely vulnerable to natural disasters. Haiti, a Caribbean island nation with the notoriety of being the poorest country in the Western Hemisphere, has one of the weakest health systems in the world. Infant and maternal mortality remain at high levels, and vaccination coverage is stagnating or declining, especially for the poorest households. And more than half the health budget comes from international aid. Surgical care outside of NGO provision is unaffordable for most Haitians. During the 2010 earthquake that struck close to the capital city of Port-au-Prince, over 600 health agencies responded, but few had the relevant experience, competence, or capacity to provide the infrastructure needed to support emergency surgical services. Most of these organizations left after 3 months, including MSF. But Haiti's surgical system was heavily reliant on donor aid prior to the earthquake and was nowhere near baseline when the majority of the aid workers left. Damiso Moyo, a Zambian global economist with degrees from Harvard and Oxford, argues in her 2009 book, Dead Aid, that all humanitarian aid is bad aid. Moyo worked as the head of economic research and strategy for sub-Saharan Africa at Goldman Sachs. She argues that the aid industry is not just ineffective, but malignant. She purports that developmental aid, including humanitarian assistance, drives recipient countries deeper into poverty, perpetuating reliance on donors, and creates disincentives to build sustainable systems. I still respect the work that MSF does globally, especially in surgical care. However, I now acknowledge that the way in which it has conducted short-term missions without a focus on local capacity building is neocolonialist in its approach. After MSF, I decided to focus my career on surgical capacity building by working with national and local governments, rather than external organizations. In 2012, I joined the Rwandan Ministry of Health through the Human Resources for Health program, an initialist to train specialists, including surgeons. After the 1994 genocide, Rwanda had one of the lowest life expectancies in the world. Doctors and nurses either fled the country or were killed, thereby decimating the health workforce. By the time I began working there, Rwanda had come extremely far. They had rebuilt their health system and registered some of the fastest declines in premature mortality in recent history. Today, nearly all Rwandans have health insurance, and life expectancy has risen by 27 years. I was seconded to the University of Rwanda's Department of Surgery, where I observed different power dynamics with various high-income country collaborators. The HRH surgeons, like myself, worked for the Rwandan Ministry of Health, which conceived and took ownership of a specific mandate to mentor and train Rwandan surgeons. Visiting surgeons like myself were not allowed to become involved in service delivery unless we were explicitly training surgical registrars. This was a difficult temptation to resist because as clinicians, surgeons love the immediacy and satisfaction of operating. However, we were there to train and build a sustainable teaching program and not to satisfy our own needs. The Department of Surgery also received short-term visitors, academic, and NGO surgeons from various high-income countries who had a more top-down neocolonialist approach than ours. One particular example stands out. 3 days before his visit, a well-known American vascular surgeon informed the department head that he was coming. On arrival, he insisted on teaching dialysis access and wanted all the surgical residents to be in the operating theater to observe him. At the time, dialysis was not available in Rwanda. Therefore, creating an arterial venous fistula was not a useful procedure for the patient. In addition, demanding an audience of all the trainees meant that the other operations, many of them emergencies, were postponed. As stated earlier by Perez Eskayama, neocolonialism starts with privilege and the belief by one group of persons that they have something to offer that another group wants or needs. This visiting surgeon felt he was being useful. He believed he had done a great service for Rwandan surgery. Since he had certain skills or knowledge that he assumed that the Rwandan surgeons wanted, there was no need to ask. This type of neocolonialist arrogance makes North-South relationships inherently unequal. The local surgeons felt powerless to voice their own views or tell him that dialysis access was not a useful skill to teach. Because he was from a well-known university, they did not want to offend him in case the relationship might be useful to them in the future. I am fairly certain that none of the Rwandan surgeons would have presented themselves to a U.S. academic department of surgery and insisted on a captive audience to teach skills that they felt were useful without an invitation. About this time, global surgery as an academic field started to take shape. Global surgery can be defined as the study and practice of improving high quality and equitable access to surgical care for all people. Several academic centers, almost all located in high-income countries, were formed. An interest by high-income surgeons to conduct short-term clinical missions in low- and middle-income countries such as Rwanda increased exponentially. professional surgical associations started entire divisions dedicated to volunteer opportunities. For example, the American College of Surgeons volunteer division is called Operation Giving Back and has 10 short-term missions options currently listed on their website for the next few months. Over the years, these individual surgeons and groups have done hundreds, if not thousands, of operations. But like other forms of humanitarian aid, the focus has been on service delivery and not local capacity building. A second focus of high-income global surgery centers has been to send their trainees to LMIC hospitals for clinical rotations. At best, these are examples of well-intended surgical tourism, but at worst, they allow ambitious residents to perform operations that otherwise they would not be allowed to do in their home country on our vulnerable populations. In addition, there has been little reciprocity about LMIC surgical trainees going to high-income countries to do clinical rotations due to limited funding and visa and medical licensing requirements. In 2015, the Lancet Commission on Global Surgery redefined global surgery through a global health lens, and the World Health Organization declared that surgical care was an essential component of universal health coverage and health systems strengthening. The focus of global surgery shifted from short-term service delivery to local capacity building and surgical systems strengthening. The Lancet Commission on Global Surgery defined certain indicators to measure surgical systems and advocate for national surgical planning. At first, global surgery advocacy and research efforts in LMICs were led by high-income country institutions. But as global surgery units are now being established in LMICs, these new entities are shifting the power dynamic and developing local research agendas and sustainable pipelines of global surgery leaders from Asia, Africa, and Latin America. At the same time in 2015, I returned to South Africa and focused my own research interests on community perceptions of surgical care and how to use this knowledge to co-create stronger surgical ecosystems. Firstly, I sought to understand how delays to optimum surgical care can arise from social determinants of health and structural violence. Understanding a patient's environment and beliefs helps us to comprehend barriers to access. One example stands out. Around 10 years ago, I was the only surgeon working in a rural district hospital in Mpumalanga. A 50-year-old Shangaan woman with a breast mass was the last patient of the day in the outpatient surgical clinic. She had numerous cross marks on her breast as she had been visiting the local Sangoma, or traditional healer, for this problem. Since the mass continued to enlarge, she decided to seek care in the formal health sector. So she went to the local clinic that referred her to our district hospital surgery clinic. She waited 4 months for that appointment. A biopsy confirmed breast cancer. Because of the size of her tumor, her treatment included neoadjuvant or pre-surgery chemotherapy that was only offered at a tertiary hospital in Johannesburg, 6 hours away. After several months of this treatment, she would undergo a mastectomy or surgical removal of her breast. I still remember that she slept on a hospital bench all night so she could take the 3 a.m. hospital transport to get to her first appointment in Johannesburg. 9 months later, she presented to our district hospital emergency department with a larger breast mass, now necrotic, as well as distant metastases to her lungs. She had not done any of the chemotherapy, nor had the operation. When I asked her why she had stopped her treatment, she gave me the following reasons. Number 1, she did not have money to buy food for the trip to Johannesburg every 3 weeks for the chemotherapy treatment. Number 2, the hospital was too far away and she could not be away from home for so long because she had children at home to take care of. 3, none of the doctors spoke Shangaan and she did not feel that they could relate to her. 4, she was afraid of the surgery and no one explained the details of the operation to her. And 5, she had no family support in Johannesburg and she did not want to have this treatment alone. So she decided to take her chances with the local Sangoma, whom she had known since she was a young girl, and receive treatment closer to home. This woman's story is not unique to Mpumalanga nor to South Africa. Barriers to accessing care are related to structural violence and social determinants of health, including poverty, lack of education, gender inequality, and perceptions of the health system. The Lancet Commission of Global Surgery uses a 3 delays framework to examine barriers to surgical care. These include delays to seeking, reaching, and receiving care. In this case, cultural beliefs and a lack of health education delayed seeking care. The multiple health system failures resulted in delays to reaching and receiving care. It took months to secure the district hospital appointment, even when the clinic recognized there was an untreated surgical condition. The district hospital where I worked did not have adequate resources to treat her breast cancer, delaying access to receiving care. And surgical care is only one component of a larger health system. Our rural district hospital lacked oncology services, forcing her to make the 6-hour journey to Johannesburg. And she dropped out of care because it was too far to travel and was in conflict with taking care of her family. In 2019, I started the Center for Global Surgery and became its inaugural director. At the center, our research focuses on identifying and mitigating these barriers to quality and timely surgical care. And some of our work has uncovered reasons why surgical care needs to be decolonized. Firstly, there is a lack of understanding of how communities and individuals perceive surgical care. Many are afraid of doctors, hospital, anesthesia, and surgery. Studies have shown that patients trust doctors and other healthcare staff that look like them. We recently analyzed the demographic profile of the surgical workforce in South Africa. The majority of surgeons in South Africa are white, male, and over the age of 65. And apartheid has left a deep mistrust of the government and, by extension, healthcare staff, especially doctors. We need to make the effort to increase the diversity of our surgical workforce. However, this will not happen overnight. We need to actively recruit medical students early in their trainings, speak at student surgical societies, and get them enthusiastic about what surgeons can do. And importantly, we need to dispel the misconception that surgery is not friendly towards women and persons of color. I am proud to say that Stellenbosch is leading the way here in South Africa with a female surgeon as head of Department of Surgical Sciences, and from 2022, another surgeon as dean of the Faculty of Medicine and Health Sciences. Christian Barnard is one of South Africa's most famous surgeons, having been credited for performing the first heart transplant in 1967. However, he would have not achieved this milestone without the sentinel work of Hamilton Naki, his assistant, who helped him with key research. Naki was a black gardener who went on to work in the animal laboratory in the University of Cape Town, and he assisted Barnard in the research efforts that preceded the first human heart transplantation. Naki came from the rural Transkei and had no access to higher education under apartheid. Yet he developed excellent technical skills. In 2003, Naki received his honorary Master's of Medicine degree from UCT, probably many years too late. Stories like this need to be told so that persons of all backgrounds know that they can become surgeons. Understanding patients' perception of health and well-being is critical to appreciating their acceptance or fears about surgical care. So often in global surgery, which seeks to understand barriers to access to surgical care, the patient is left out of the conversation. Epistemic injustice is injustice related to knowledge. Who is the expert? In global surgery, there is a distinct hierarchy. First, the surgeon knows best, then maybe the anesthesiologist, and sometimes the nurses. But the persons with the surgical conditions and their communities are rarely included in research to improve care. If we want to decolonize global surgery, we need to rethink this critical exclusion. Global health specialist Hemani Bakuni and Seya Ambibola wrote in a recent editorial, "Epistemic injustice is a cycle in which researchers assume that locals in marginalized areas and members of marginalized groups do not have the capacity to contribute to research and thereby bypass such people's participation. In doing so, the more the local knowers and members of marginalized groups are bypassed, the further they are marginalized." Secondly, the neo-colonialist approach fails to consider the multidimensionality of health. Doctors often believe that surgical conditions require a biomedical magic bullet cure but patients do not always accept this approach. My patient delayed seeking care in the formal sector and sought a traditional healer or sangoma first. In many parts of the world, local beliefs around the causes of illness are not purely biomedical. Some believe that they may have angered past ancestors or that there's an imbalance in a particular relationship that needs to be fixed. Efforts need to be made to demystify surgery. Modern surgery is a very Euro-Western-centric, with emphasis on the need for state-of-the-art and expensive inpatient-based technology. While science and innovation have improved surgical techniques, they are not useful if patients cannot or do not want to seek surgical care. Understanding indigenous health systems and beliefs are essential to appreciating reasons why persons with surgical conditions might seek alternative care. One solution is to work with traditional healers rather than viewing them as barriers. A qualitative study in Ghana, where traditional bone setters manage fractures in the community without formal education, showed that the vast majority wanted to work with the formal health sector. Successful collaboration with bone setters in Ethiopia and Nigeria have resulted in fewer amputations, infections, and malunions. In South Africa, structural violence is intimately linked to physical violence. Our country has a high rate of trauma, and deaths from injury is 7 times higher than the global average. Intentional injury in South Africa is common in informal urban settlements. Don Pienack of the UCT Center for Criminology details Cape Town's high rate of gangsterism in his book Gangtown. He explains that forced migration of colored persons to the Cape Flats broke up communities and families, destroying a system of social accountability. The youth were left without a sense of belonging and turned to gangsterism to regain a sense of sharedness. We know that gang violence plays a major role in the cause of intentional injury, but gang violence is also a barrier to seeking care. People who live in areas of high crime are afraid to seek care due to the insecurity of traveling to health facility, especially at night. Private transport is uncommon for those without money, and public transportation is unreliable and unsafe. Crime and the lack of safe public transportation are also barriers to reaching timely care. Ambulances do not go to certain areas without a police escort due to the high incidence of hijacking. Our work has shown that waiting for police escorts can significantly delay reaching care, and for certain traumatic injuries such as a gunshot wound to the chest, every minute is critical to life. Structural violence also leads to high rates of alcohol abuse in the lower socioeconomic classes. Dr. Claire Herwick, a professor of demography and global health at Imperial College, studied risky alcohol consumption in the Cape Flats and concluded it is a form of coping, escapism, and pleasure under situations of structural violence. The relationship of alcohol abuse and traumatic injuries and homicide in South Africa is clear, but our work shows that it also delays seeking care for injury. Persons who are intoxicated do not always recognize the need for care or the severity of their injury. In summary, various components of structural violence are interrelated, and addressing these will be major steps in the decolonization of health care, including surgical care. Another important step to decolonize surgical care is to increase its physical accessibility to more communities, especially marginalized groups such as people living in rural areas. The patient I described did not end up completing her care as her treatment took her far away from her family and friends. Family support has been shown to improve quality of life after surgery. In addition, a patient should not have to choose either to get better from her surgical condition or be with her family. The Lancet Commission on Global Surgery recommends that all people should live within 2 hours of essential and emergency surgical care. And the WHO has stated that the district hospital should deliver the majority of this care. Our work has demonstrated that greater than 90% of South Africans live within 2 hours of a district hospital. However, most of these facilities do not have surgical capacity. The South African National Department of Health has listed 100 procedures that should be included in the district hospital service package. However, there is not adequate resources such as equipment, infrastructure, and workforce to deliver this care. For example, fully trained surgeons and anesthetists rarely work at district hospitals. Family physicians receive training in certain surgery and anesthesia competencies, but these are not aligned with the district hospital service package. Mentorship from surgical specialists and buy-in from relevant stakeholders are needed to make district hospital surgery a reality. In summary, I have outlined several steps about how we, the global surgery community, can decolonize surgery. 1. Shift the power dynamic locally and globally by combating epistemic injustice. We can do this locally by including the community and persons with surgical conditions in global surgery advocacy and research. Globally, this can be done by supporting the premise that LMIC global surgery clinicians and researchers know about barriers to access to care in their own settings and can lead South-North collaborations. 2, replace short-term service delivery efforts by international teams with co-creation of sustainable surgical health systems by local surgical teams and communities. 3, build a sustainable pipeline of young global surgery leaders in LMICs. 4, diversify the surgical workforce. 5, address structural violence in order to reduce delays to surgical care. 6, bring surgical care closer to the community. 7, demystify surgery by acknowledging it is only one component in achieving health and well-being. And 8, make physical access easier by strengthening decentralized surgical services. In conclusion, surgical care saves lives, yet billions still do not have equitable access, mostly in LMICs. The reasons for this are multiple, but a significant factor is one's accident of birth, where you were born, and what the social economic status of your family is, and your ethnicity all play a significant role in the type of surgical care that you will receive. Colonialism and neocolonialism have played a role in defining surgery, its ideals, and its current reputation. It has been my great pleasure to be the inaugural director for the Center for Global Surgery. This position is the culmination of my various paths and endeavors. My personal journey in surgical care has been one intertwined with privilege and neocolonialism. I was born in a high-income country, and in my global surgery relationships, I have been both the oppressed and the oppressor. I have spent years working in humanitarian assistance, which may have helped save lives in the short run, but likely contributed to economic dependence on wealthier Western countries with minimal health system strengthening and capacity building. Now I feel extremely fortunate to be part of a movement to build African capacity in global surgery research, service delivery, and health systems strengthening. As the Chinese proverb goes, the best time to plant a tree was 20 years ago. The second best time is now. Let us not waste any more time. Let us be disruptive. Let us have those uncomfortable conversations to increase inclusivity in the fight to champion equitable access to timely surgical care for all. I would like to thank my parents, Andy and Diane Chu, for their resilience to immigrate to the United States in search of a better education, life, and political stability. Thank you for giving my sister and I every educational opportunity and to live the American dream. Thank you to my husband, Greg Simpson, for his unwavering support of my academic career, and my children for keeping me sane. Thank you to my first research mentor, Nathan Ford, former head of the MSF South African Medical Unit, for recognizing that surgery is an essential component of public health worth writing about. And finally, I would like to thank Professor Jimmy Fulmink, who is completing his 11th and final year as the Dean of the Faculty of Medicine and Health Sciences, for believing in me enough to take me on in your faculty. Thank you.
Thank you, Professor Chu. Colleagues, family and friends, as you know, inaugural lectures are a central part of university life, of academic life, and are held to commemorate the inaugural lecturer's appointment to full professorship. It is a celebration of achievement and the academic recognition, signifying a defining moment in any academic's career, highlighting the significant contributions that the individual has made to the field. As such, it's really a special occasion, and we are glad that you were able to join us here today to share this event with us and with Professor Chu. Thank you, Professor Chu, for taking us on a fascinating journey through your life and for showing us not only your lifelong commitment to understanding the barriers of surgical access, clearly motivating in your lecture to be in part a consequence of structural violence and new colonialism, but also your endeavors to trying to address these issues and to build capacity in research and training in surgical care in global surgery in order to form a pipeline of future global surgery leaders through capacity building and mentorship. We know that global surgery has been a neglected topic within global and public health arenas, and that billions of people worldwide lack access to safe, affordable surgical anesthesia care when needed, the majority of whom live in low and middle income countries. We also know that serious injuries, a large percentage requiring surgical interventions, is one of the major burdens of disease conditions in South Africa and on the continent. And in the Western Cape specifically, we know that we live in one of the most unequal parts of the world, and that providing improved and equitable surgical care across our continent therefore remains a really extremely important imperative. Your efforts to create the opportunities, expertise and knowledge in this field is commendable. Inter alia, being the founder of AfroSurge, a South African initiative to improve surgical access in the region, and for example, being the member of the Southern African Development Community National Surgery Obstetric Anesthesia Task Team and the South African NSOAP Task Team. Global surgery sits in the interface between numerous clinical and non-clinical specialisms, encompassing multiple aspects that surround the surgical treatment and its equitable provision across health systems globally. It is clear from your lecture, Professor Chu, that you have mastered this difficult and complex interface with passion and excellence. Thank you for highlighting that surgery saves lives, and therefore that surgery should be accessible to all. Thank you also for showing us that surgical access at the moment is highly inequitable, and that it starts with a bottom-up advocacy and grassroots buy-in to co-create sustainable surgical systems to improve good health and well-being for all. That surgical care should be viewed as a holistic component of health and well-being. Your lifelong commitment and efforts in these endeavors do not go unnoticed. Thank you very much for being a valued colleague, for representing our faculty and university in this discipline, not only nationally, but on the global stage. For example, being part of the Consortium for Universities of Global Health and the One-to-One Africa. We look forward to your ongoing contributions to our faculty, to the university, to South Africa and the continent, and we look forward to seeing your vision of surgical care being a real, tangible and essential component of universal health care and health system strengthening becoming a reality. Thank you very much.